Hello, everyone. Thanks for waiting. Welcome to the third installment of our webinar series on maximizing third-party reimbursement through enhanced medical documentation and coding with Stacey Murphy. Sorry about that, little technical difficulty. So before we start, I'll just tell you a little bit about Health HIV. I'm Samantha Ritter, the training manager here. We operate with 4 core capabilities: capacity building, advocacy, health services, research and evaluation, and education and training, working across HIV, hepatitis C, and LGBT health issues. This is fiscal health from systems to sustainability under our education and training program. And fiscal health systems to sustainability is a HRSA HAB funded program that provides training and technical assistance for Ryan White funded organizations to build their fiscal management capacity. We have a couple of upcoming regional trainings, one on April 19th and 20th in Newark, New Jersey, and one on May 24th and 25th in St. Paul, Minnesota. And these are 2-day trainings for Ryan White funded organizations, and everyone parts A through F are invited to both of them. And just more what we have here on Webinado. So in the folder icon, oops, sorry, that skips ahead. On the bottom of the screen, we have the slides for today's presentation, and we also have a registration link for our 4th webinar if you haven't already registered. And we'll be having interactive polling today again, and if you have any questions, technical or otherwise, please feel free to ask in the chat box on the left side of the screen. And the last of our webinar series will be next Thursday. It'll be a summary of everything that we've discussed so far. And Stacey Murphy, our presenter today, I'll introduce her again as I have every week, has 30 years of practice management, physician credentialing, recredentialing, contract management, and coding and clinical documentation experience. She's a certified professional coder, a registered health information administrator, and is also credentialed as an ICD-10, ICD-10 PCS approved trainer. And Stacey, I'm going to hand it over to you.
Oh, perfect. Good afternoon, everyone. Welcome to our 3rd installment of maximizing third-party reimbursement through enhanced medical record documentation and coding. Today's webinar series will focus purely on the diagnosis codes. I'm sure as many of you are aware, we didn't get there yet, this is our disclaimer, our learning outcomes. Today we'll discuss briefly the ICD-9 codes that you used through October 31st, 2015. And I'm putting emphasis on that because we will be playing around with those dates when we look at some of our polling questions. We'll also identify the various ICD-10 codes that describe AIDS and HIV patient care. We'll look at the ICD-10 coding guidelines for AIDS and HIV patient care, explain the difference between the various codes that are used, explain the diagnosis code selection process, and explain the importance of proper code sequencing. The next 2 slides are just the acronyms that are used in the presentation. So let's look at our very first polling question for today. What role do you play at your healthcare center or facility? Are you 1, clinical staff, such as a physician, nurse practitioner? Are you the office manager, supervisor, front desk staff, or patient registration? Are you doing the billing functions or the coding functions for your facilities or for your doctor's offices, or other? Please cast your votes. Okay, it looks like everyone's finished weighing in on our first polling question. It would be interesting to know what the other category is, as it appears that 50% of our webinar participants are in the other category. We have 14% that are clinical staff, 23% are office managers, supervisors, etc. And we have a small percentage of billers and coders that are on the call today. Okay, so just a couple of tidbits of information regarding the Affordable Care Act. It covers preventive well visit services and other services. So if you look at the short list on the slide, some of the services that are covered, one-time abdominal aortic aneurysm screening, depression screening, diet counseling, HIV screening. So that's one of the services that's also covered under the Affordable Care Act. Immunization screenings, obesity screening, and I'm sorry, it's there twice, obesity screening and counseling. So today's presentation will focus purely on HIV, the codes that are specific to HIV and AIDS care, some of the additional services that are covered for women, including pregnant women, cervical cancer screening, HIV screening, HPV testing, and osteoporosis, services for infants, children, and adolescents, behavioral assessments, height, weight, and BMI, HIV screening in adolescents, obesity screening, and counseling. And so I've underlined the HIV screening because, again, for the purpose of this webinar today, we will only focus on the codes that are pertinent to AIDS and HIV care. So let's do another quick polling question before we really get rocking and rolling today. So if you'll notice, there's a doctor asking the question, there's over 140,000 ICD-10 codes. What are ICD-10 codes? So I wanted to know how many people on the call today possess a familiarity with ICD-10 codes. So please cast your votes. Okay, so it looks like we have 80% of our webinar participants are familiar with ICD-10, and then we have a percentage, 22%, that are not so familiar. So I hope after today's webinar series that you take away a very comprehensive understanding of the ICD-10 coding system. So let's talk very briefly about the code system that was phased out. The ICD-9 coding system, it was developed in 1948 by the World Health Organization. Here in the U.S., it was mostly used for statistical purposes, morbidity and mortality. But in 1988, CMS made the decision that all claims would comprise of an ICD-9 code. And so as it stands today, we are still required to report codes, but now we're using the ICD-10 codes, not the 9 codes. The ICD-9 codes describe medical conditions, diseases, injuries, and poisoning. The ICD-9 code set, as well as ICD-10, as we will see when we move into it, also comprises of codes that describe patients that are not sick but come in contact with the healthcare delivery system. So it's not just medical care, it's codes for patients that are sick or not sick that require medical attention. The ICD-9 coding system was phased out on October the 1st of last year, and it was replaced with two new coding systems, ICD-10-CM and ICD-10-PCS. For the purposes of this webinar series, we will only focus on the ICD-10-CM coding system because the ICD-10-PCS codes are not used in the private practice setting. These codes are used on institutional hospital claims and reported for facility bills. So these would never be reported on any professional claims that you are, for any professional claims that you're submitting to your health insurance carriers in your practices. In terms of reporting, code reporting, the only effect for the 22% of the webinar participants in terms of codes, you will still continue to report CPT codes and HCPCS codes. The ICD-9 phase out only affects the diagnosis codes. So we phased out ICD-9 codes, and we are currently using ICD-10 codes. Some of the practices that I have been working with, they still have a few outstanding claims from last year. And so in terms of reporting, if you still have any claims that are through the service date September 30th, 2015, you will still continue to use ICD-9 codes for any of those old claims that you're cleaning up, because we have a lot of cleanup efforts going on in terms of old claims. Maybe the patient came in and at the time they didn't provide you with the correct insurance information, and so now you have to resubmit claims to the correct carrier. So you would continue to report ICD-9 for those services through September 30th. On October the 1st, when the new code set was implemented, ICD-9 was phased out, and now you are using, going forward, just the ICD-10 code system. So what has changed? For those of you that have been using ICD-9 for many, many years, as I have, you know that in the ICD-9 coding book, there are 2 volumes that you utilize in the professional practice. That's volumes 1 and 2. There are approximately 13,000 codes in that set, versus in ICD-10, which we'll see a few of those today, there's approximately 7,000. Your codes in ICD-9 were 3 to 5 character lengths. We will see codes in ICD-10 that have as many as 7 characters. So there is a very distinct difference in how the codes look in terms of ICD-9 versus ICD-10. Other changes, there is a significant change in a lot of the terminology. So there's new terminology, there's revised terminology. There are an increase in the number of available codes that reflect laterality. So we have some codes that designate left side versus right side. There is also an increase in codes that reflect the episode of care, initial versus subsequent versus sequela. There's a lot of codes that reflect specificity. And so for the first year, most of the payers have agreed to waive any denials in terms of if you're submitting claims that where you're using unspecified codes. Because under the ICD-9 system, they weren't, the codes were exhausted, and there was no room for additional updates to provide specific codes. But in ICD-10, there are 70,000 plus codes. There is a lot of codes that detail specificity. We also have some codes that have increased combination codes. And so it's very important that in terms of claim submission in ICD-10 for the current time frame, that next year you ensure that you are submitting the most specific ICD-10 code to reduce the possibility of your claims being denied. The hypertension table no longer exists. So in ICD-9, there was a hypertension table in the alphabetic index. That does not exist in ICD-9, in ICD-10. The V codes and the E codes, well, the V codes that you use to describe well visits and patients that are HIV positive, those codes were contained in the supplementary classification section of the ICD-9 book. In ICD-10, there is no supplementary classification. These codes now have been reclassified to its own section, thus the change from 17 chapters in I-9 to 21 chapters in I-10. The V codes that you used in ICD-9 are now Z codes in ICD-10. If you're familiar with E codes in ICD-9, those are now V codes in ICD-10. There are also W, X, and Y codes. So you really should take the time to familiarize yourself with the codes that you are commonly using in your practices to make sure that you are submitting, that you're utilizing the most appropriate codes for the services that are being provided by the physicians in your practice. There's code expansion. And in terms of code expansion and what that means, there are codes oops, I'm sorry. I wanted to use the pencil. Okay. There are codes that require 7 characters, and in order to get your 7-character designation, you may have to utilize the X as a dummy placeholder, and I'll show you in a minute what that looks like. The dummy placeholder X is used for external causes of injuries, and I'm starting from the bottom because the stuff that's at the top may not necessarily apply to your practice. Injuries, postoperative complications, substance abuse, there's diabetes, and there's inclusion of trimesters in the obstetric codes. In the ICD-10 code book, there are 2 types of 7th character designations. One denotes the episode of care, meaning initial versus subsequent versus sequela. And the other one, which is the one here in blue, denotes that you have to utilize the dummy placeholder X in order to have a complete code. And so if you look in terms of the codes with the episode of care, the 7th character that reflects episode of care is for initial encounter, subsequent encounter, and sequela. And we do have a few scenarios in this webinar series to show you the distinction between the 7th character A, D, and S. In terms of how it's used, it's commonly used for services in the musculoskeletal system section and injury, poisoning, and certain other consequences of external causes. So those are typically the 2 most common times where you'll see a code that ends in the alpha A, D, or S. There are also changes with the Exclude coding guidelines. For those of you that are familiar with the ICD-9 coding system, there were 2 designations. There was Excludes and there was Includes. Well, in ICD-10, there's Includes, there's Excludes 1, and Excludes 2. The Excludes 1 just means the same thing that it meant in ICD-9, and it basically states that you should never report the code that you are reviewing. So if you're looking in a code book and you see a code that has this Excludes 1 designation, that means that the 2 codes that you're trying to report can be reported together. You can only report one. Versus the Excludes 2 is telling you that the medical condition may not necessarily be a part of that condition that you're coding, and in that case, you can assign both codes together. Now, in terms of the services that we will be discussing today, you more than likely will not come in contact with any Excludes 1 or Excludes 2. These Excludes 1, Excludes 2 notes are more so for more common in the medical diseases section. And when we get to some of the codes, if there are some any Excludes 1 or 2 notes, I'll point those out for you. In terms of changes, we indicated that there are now 21 chapters in ICD-10. So here on this slide, you'll see 2 of the new sections. In ICD-9, the eye and adnexa and ear and mastoid, those were part of the nervous system, and the decision was made to carve these sections out and make them their own section. So the eye and adnexa are Chapter 7 codes, and they begin with the letter H, 00 through H59. And the diseases of the ear and mastoid process are carved out also, and they are codes within the H60 through H95 section. The other 2 sections are the external cause of morbidity and the factors influencing health status and contact with health services. So if you recall in your ICD-9 books, these were part of the supplementary classification sections. Well, now in ICD-10, these codes have their own chapter. The external cause codes are morbidity codes, V00 through Y99, and the factors influencing health status and contact with health service section is Z00 through Z99. So these codes here are the V codes that you used to use. And now if you'll notice, your V codes are external cause codes. So according to the official ICD-10 coding guidelines, here are some of the terminology that's used to describe the condition AIDS for code B20. And again, going back to ICD-9, the code for AIDS in ICD-9 was 042. So there really hasn't been any changes in the terminology. It's pretty much the same. The official coding guidelines mirror, the official coding guidelines in ICD-10 mirror the official coding guidelines in ICD-9. Code only confirmed cases of HIV infection or illness. So this has not changed. In the context of confirmation, the code book says that it does not require documentation of a positive serology as long as there is a statement from the physician that the patient has AIDS or they're HIV positive. That is sufficient enough for a coder to assign the code. Now, even though the code book says this, I often tell coders, if you work in a practice setting where you have established a rapport with the patients, you may sometimes want to just double check with the provider to make sure that the information that is documented in the record is correct. Because, you know, human error, we all make mistakes. And so you just want to make sure that when reporting these codes, that you're reporting these codes accurately. So here's some additional coding guidelines, and these are right from the ICD-10 official coding guidelines, right from the book. Selection and code sequencing. In the context of admission, when a patient comes to your office, the final diagnosis that the physician establishes is AIDS or an HIV-related condition, then that would be the final diagnosis that is reported on that particular patient's encounter. So in terms of the information on the slide, if the patient presents to your office for treatment of AIDS or an AIDS-related condition, then the principal diagnosis should be AIDS or the HIV positive code. If the patient presents for another medical condition, such as they have a fracture, or maybe they have a headache or some other medical condition, but they also have AIDS or they have HIV infection, the principal diagnosis should be the reason for the patient presenting to your practice. In that instance, I'm sorry, hold on one second. Okay, I apologize. And so if the patient presents to your practice for some other problem that's not related to the AIDS or HIV infection, the principal diagnosis should be the reason why they presented to your practice. And the secondary diagnosis or third or additional code can be reported with the AIDS, which is B20 on this slide, or the Z21, which is the HIV infection code, which we'll look at when we get to future slides. So here are some additional ICD-10 coding guidelines. Newly diagnosed patient. In terms of documentation, it's very important that the documentation is crystal clear so that if you have someone in your practice that's responsible for coding, they are able to extract the information and appropriately assign codes. And that doesn't just apply to this discussion or today's webinar series. That's across the board. It's very important that the documentation is clear so that whoever's responsible for assigning the codes can select the appropriate codes and can also sequence the codes based upon your documentation. So now in the previous slides, we were looking at the codes for AIDS. The code for HIV positive is Z21. If you remember in ICD-9, the code for HIV positive was B08. So again, the coding guidelines for the most part have not changed. It's just the codes that have changed and how the codes look. That's the only thing that has changed. Another code, some additional coding guidelines. Patients with inconclusive HIV, R75. So patients with inconclusive tests should be assigned R75. So in that case, you would not use the B20, which is the code for AIDS, or that Z21, which is the code for HIV positive. And Section F of the coding guidelines indicate that these codes should never be reported together. So if you look at the final statement here, patients previously diagnosed with any AIDS or HIV illness should never be assigned the inconclusive code or the HIV positive code. So just some additional coding guidelines that are here for you in terms of testing. So let's look at some more tidbits of information so that we can get right to the codes, because there are a lot of slides with codes and coding examples. But in a nutshell, according to the Centers for Disease Control, in order to diagnose a patient with AIDS, there must be documentation from the provider. If the patient's diagnosis indicates that they have AIDS or an AIDS-defining medical condition, also known as an opportunistic infection, and you have to select the most appropriate code based on the documentation. There are codes for HIV-1 and HIV-2. HIV-1 is common here in the U.S. HIV-2 is not so common here. It's mostly abroad in other countries. And so you may have patients that come to your practice from other countries, and they may have a diagnosis of HIV-2. And so we'll see the codes in terms of the types of codes that are available for you and how to report those. Important to note that HIV positive is not the same as a patient that has the AIDS infection. So to reiterate, these codes should never be reported together. HIV positive and inconclusive HIV is not the same, and these codes are never reported together. If a patient has the HIV-2 virus, you would report the HIV-1 code, which is B20, and the HIV-2 code, which I don't recall off the top of my head what it is, but we'll see it in a few moments when we get to the slides. Inconclusive HIV testing, specific to newborn babies that are born to moms that are HIV positive. They typically have the antibody status, and it lasts for up to 18 months. Now, this status may never affect the newborn, and they may never become infected with the AIDS virus, and this is known as false positive. False positive is also known as inconclusive HIV test. So that was the R75 code that we were looking at. In terms of documentation, assign inconclusive test code when documentation is lacking and it does not definitively state that the patient has the virus, the AIDS virus, or that the patient has HIV infection, has HIV positive infection. So this slide talks about the stages. According to the National Institute of Health, there are 3 stages: acute HIV, chronic HIV infection, which is broken up into 2 phases: asymptomatic for approximately 5 to 10 years, and then symptomatic for another 1 to 3 years. But according to other data that's out there, the other data suggests that there are 4 stages. So the 4th stage is here for you. It's chronic HIV to AIDS, which is basically advanced stages of the HIV infection, where patients most of the time are develop opportunistic infections. People with healthy immune systems are oftentimes exposed to the 4 infections that are here on the slides, and they have no reactions. But for patients whose immune systems are compromised, who may have AIDS, these infections oftentimes compromise their health, and these are the most common opportunistic infections that compromise the care and the health of a patient that has AIDS or is HIV positive. So in terms of the most common opportunistic infections, here's a short list: candidiasis, cytomegalovirus, herpes simplex, Kaposi sarcoma, wasting syndrome, tuberculosis. So if you want a complete list of all of those opportunistic infections, you can go to the CDC's website. But this is just a short list of those that are most common. So let's look at another polling question. Thinking back to the very beginning of this webinar, of this webinar series, for services that are rendered to a patient, let's say you have those outstanding claims that I spoke about earlier, for services rendered to a patient in your office on date of service, October the 28th, would you report ICD-9 codes? True or false? Please cast your votes. Okay, so it looks like we have 72% of our webinar participants say that that's false, and we have 27% that say that this is true. So just to confirm, the ICD-9 code system was phased out on October the 1st, 2015. It was phased out on September the 31st, the end of September the 30th, It was phased out on September the 30th, and on October the 1st is when everyone in the country began using ICD-10. Now, there are some exceptions to some of the practices that began using the ICD-10 code system. There were some insurance plans that were not required under HIPAA to utilize the ICD-10 codes. So that would be like disability carriers, workman's comp carriers. So they weren't mandated to switch, but everyone else was required to begin using ICD-10 codes on October the 1st, 2015. So if you answered true, your answer was incorrect, because everyone, with the exception of workers' comp carriers, disability carriers, were supposed to begin using the ICD-10 codes. And so for the purposes of this presentation, because we are discussing the services that are for patients that have AIDS or HIV, you should have been using ICD-10 codes on October the 28th, 2015. Okay, so now let's look at some of the codes. Most of the webinar participants expressed that they are familiar with the ICD-10 codes, but there was about 23 or 25% that did not have a understanding of the code set. So what I did for the purposes of this webinar series is I also included the old codes that you may be familiar with in tandem with the new codes that you should be using now. So that way you'll see the distinct differences. So for the patients that are diagnosed with AIDS or the AIDS infection, in ICD-10, the code is B20. So that's what you should be using for any services that are provided to patients on or after October the 1st. If the patient is HIV positive, then you should be reporting Z21. Some additional codes, inconclusive HIV testing, the code is R75. For patients that are coming in for HIV counseling, the code is Z71.7, compared to the code that was used prior to the implementation of ICD-10, Z6544. So now we're using Z71.7. The special screening codes, there are two of them here. Special screening would be the services where the patients are having, the patients that are getting HIV testing, I apologize. So there are two codes here, but the one that you would be using specifically for patients that are being screened for HIV is Z11.4. This Z11.59 is for all other viral screening tests. Z20.6 describes pre-exposure prophylaxis. In ICD-9, the code was V01.79. But believe it or not, I did quite a few chart audits and webinar series in the past, and there was not a high level of understanding about the use of the V0179 when it was ICD-9. And so it's important that if a patient comes in contact with or exposed to another patient that has the AIDS infection or HIV positive, and you're going to do any prophylactic testing or anything of that nature, the diagnosis code that you will be utilizing to describe that is Z20.6. In ICD-9, there was only one code that described high-risk behavior, but in ICD-10, the decision was made to take the code and break it into three different codes. High risk for heterosexual behavior, Z7251. High risk for homosexual behavior, Z72.52. And high risk bisexual behavior, Z72.53. So now you have the three codes versus the one code that was in existence in ICD-9. Problems related to lifestyle, Z72.89. So let's say your patient population, patients that are you are sharing needles, you would include the Z72.89 on your service claims that you're submitting. Some additional codes, human T-cell virus, B97.34, the HIV-2 code, B97.35, encounter for procedures for purposes other than remedy in health, which is another code described as other specified prophylactic measure in ICD-9. That code is Z41.8. And we have a Z11.3, encounter for screening for infectious with a predominantly sexual mode of transmission. So if you'll notice, their ICD-10 coding system is a little more specific in some instances, but then in other cases it may not be as specific. The code B58.69 in ICD-9 for long-term use of medications is a 6-digit code in ICD-10, Z79.899. The bottom of the screen, there are some tidbits of notes that are located in the ICD-10 book. So here's an example of the Excludes tool. If you go back to that slide where we were talking about Excludes 1, Excludes 2. In the ICD-9 code book, the instructional notes state, code also any therapeutic drug level monitoring. So if the physician is monitoring the medications, then you would also report this code. There's an Excludes 2 note that says if the patient is drug abuse or dependence, that you have to report a code that describes that. If the drugs or medication complicates the patient's pregnancy, then you have to report a code from the pregnancy section. And so if you'll notice, the code 0.99, not 0.99. Here are some codes that describe the opportunistic infection. So candidiasis, the code ranges in I-9 was 112.0 to 112.9. The code ranges in ICD-10 are B37.0 through B37.9. Cytomegalovirus had one code in I-9. There's a code range in ICD-10, B25.0 through B25.9. HSV, the code ranges was 05410 through 05419. The code ranges in ICD-10 is A 60.00 through A as an apple 69. So these two slides just provide you with, the commonly used codes for the opportunistic infections. And just to reiterate, anytime a patient has documentation that supports that they have any of these opportunistic infections and they are a patient that has the HIV infection or AIDS, the opportunistic codes are reported as the secondary code. They would never be sequenced as the principal. I added this code set to the slides because in one of the webinar series that I did, they asked about a patient that was treated in the practice, and one of the office staff accidentally stuck themselves. So I included that on this webinar series. So in ICD-9, it's an employee, such as a medical office assistant or an RN or an LPN, that's drawing the blood work accidentally sticks themselves. In ICD-9, the additional code that would have been reported after you report the code for screening and pre-exposure prophylaxis, the additional code would have been E920.5. But in ICD-10, you'll notice there are 6 different codes to choose from. And earlier in the webinar, we spoke about the codes that end in A, D, or S. So if you'll notice, the first 3 codes say contact with hypodermic needle, initial encounter, subsequent encounter, and sequela. And the bottom 3 codes are contact with contaminated hypodermic needle, initial, subsequent, or sequela. Now, in the context of the definitions of initial versus subsequent, initial does not describe the patient's being seen the very first time. It describes care in active status or active phase. So as long as the patient is being treated and the care that's being provided reflects active treatment, then every time that patient presents to your practice, you would always report the code that ends with the letter A. Once the physician has determined that the patient no longer requires any treatment, then you would utilize the code that describes subsequent that ends with the letter D. If the patient develops a new problem as a result of the prior medical conditions, then you would select the code that ends with the letter S for sequela. Sequela means after the fact. So patient's treatment is the patient is no longer being treated for that old problem, but now they have a new problem. And so here, jumped ahead of myself. So here is a description here. So A is initial, D is for subsequent, and S is for sequela. The sequela or residual effect of a previously treated condition. I also included some codes for patients that are pregnant because in some of the prior webinar series that I did, we had some patients, some questions regarding the appropriate use of codes for patients that are pregnant. So if you have patients in your practice that you are treating for any HIV infection or HIV positive, and they're pregnant, the pregnancy codes are always sequenced as the first listed code unless the coding guidelines state otherwise. So in general, the coding guidelines state that the pregnancy codes take precedence over any other codes in the code book. So here are the codes for your pregnant patients, and there's a dash here because it's missing a digit that describes the trimester. First trimester, second trimester, or third trimester. And so once again, I was ahead of myself. So when you go back to this, on the ICD-9 side, the X denotes the 5th digit, 0, 1, 2, 3, or 4. 0 describes your unspecified episode of care. 1 is delivered, which you wouldn't be treating in an office setting. These codes are commonly used in the inpatient hospital setting. The codes that you would be using in your practice are the antepartum and the postpartum, which would be your prenatal care and your postpartum care. On the, on the ICD-10 side, the 3 codes with the dashes, so those codes would utilize the episode of care stated as first trimester, second trimester, third trimester, which is 9 for unspecified trimester, 0 for unspecified episode of care. Here's some additional codes that you may utilize for patients that are presenting to your practice and they're pregnant. So these codes may be familiar to you if you're using those in your practice. If we have any individuals on the webinar that provide OBGYN services, patients that come in for normal routine follow-up care. I'm sorry, hold on one second. Okay, I'm sorry. I apologize. So if you're treating patients that are pregnant and they're coming in for routine follow-up care, or they're coming to your practice for the first time, or the first pregnancy, the principal diagnosis would be Z34.00 if these are patients that are coming in for prenatal care. If it's anything other than the first pregnancy, then it would be Z34.80. There's a code here for patients that come in for other than pregnancy-related issues. So let's say, for example, a pregnant patient comes in because they sprained their ankle. The ankle sprain has no impact on the pregnancy. So the code for the ankle sprain would be sequenced first. And the code that denotes that the patient is pregnant would be Z33.1. So that's a code that you should keep in mind as well. This slide just gives you some tidbits of information about the pregnant patient slides that we just went over. So I'm going to bypass those so that I can get back into talking about the codes that are commonly used for AIDS and HIV care. Most commonly when patients come in for testing, a lot of times they're coming in for well visits. So I put the well visits codes on the slides for you. And so if you work in a practice where you're providing well visits or well care to adult patients or adolescent patients, here are the codes that you would use, Z00.00 and Z00.01. If you're providing care to infants or newborns, these would be the codes you would use, Z00.121 and Z00.129. Actually, the newborn codes are a different code set, but these codes are for the infants. If you'll notice on the slides, you'll see that the codes have a designation of with abnormal findings versus without abnormal findings, according to the coding guidelines. And at the present, that's still being reviewed to determine if we're going to continue following that process. But at the present, in order to select the code that describes with abnormal findings, the patient would have come into your practice for a well visit, and at the time of that encounter, there would have been a review of lab work, so a physical lab or some type of a radiologic or a diagnostic test result that resulted in abnormal findings. And in that instance, you would report Z00.01. If it's an infant or a child, you would report Z00.121. And then the additional code that describes what those abnormal findings are would be reported on that claim as well. Now, if the patient comes in and they've had their well visit this encounter, and you're drawing the labs this encounter, and they return to you at a later date for the results, then you would not be using these codes. You would now report the codes that describe whatever those abnormal findings are, or if they have a specific complaint when they return, you would report those codes in lieu of the well-visit code. So these are your other codes for your supervision of newborns under the age of 8 days, and then the other code for 8 to 28 days. And in your ICD-10 set, you'll notice these are 6-digit codes, Z00.110 and Z00.111, and there are specific coding instructions saying, oops, I apologize. There are specific coding instructions that state to use an additional code if there's any abnormal findings. If there are no abnormal findings, then you don't need to use any additional codes. So if you go back to the previous slide, the coding guidelines provided you with 2 sets of codes, one that was without and one that was with. But for the newborns, there's only 1 set of codes, and the instructions just denote if there are any abnormal findings, you would just report whatever those abnormal findings are. So these are the coding changes that we just discussed in terms of which code you would select, how you would select the code. And so again, it has to be based on diagnostic test findings at the time of the encounter in order for you to report the code that denotes with abnormal findings. Some additional codes that are available, other specified counseling. So if you're providing any other type of counseling services to the patient, if you'll notice in ICD-9, the code was very specific, but they made the decision to make it a code that's a little more generic in the interest of patient confidentiality. They have these other codes. If you'll notice, there's a code that is specific in I-9, but it maps to 3 different codes in I-10. You have Z70.0, counseling related to sexual attitude, Z70.1, counseling related to patient sexual behavior and orientation, and you have Z70.3, counseling related to sexual behavior and orientation of third parties, such as a child, a partner, or a spouse. Another type of code that was commonly used in ICD-9, B67.9 for unspecified follow-up exam, and ICD-10 now has 2 codes. One code is specific for follow-up care for treatment of a cancerous condition, and Z09 is everything other than cancer. So if a patient is coming in for follow-up care and treatment is resolved, and now you're just following them, then you could utilize the Z09, unless, of course, it's a patient that has a cancer condition that you're following. Some additional diagnosis coding tips. We discussed never report the codes for AIDS or HIV positive, specifically when the medical record states suspected, suspicion of, possible, likely, rule out, questionable, consistent with, presumed to be, or appears. So if the medical record states any of these terminology, any of this terminology that's here on the slide, the coding guidelines state that you have to report the presenting complaint, the chief complaint, or the signs or symptoms. So for example, if the patient comes in complaining of muscle aches, rash, or some type of ulcers, and at the time when they come in, there's no definitive documentation to support reporting the code for AIDS or the code for HIV positive, then you should be reporting one of the codes that describe the reason why they presented to your practice. If you have access to the physician, for example, if they work in the practice where you're doing the coding or the billing, you could query the physician for specific information, but make sure that they document specifically whether the patient has AIDS or they're HIV positive. It still has to be documented in that particular patient's medical record. Active versus history of. In terms of ICD-10, active translates to the patient having the condition in the current. And in that case, it depends on what's been documented in the patient's record. So if the patient's record states that they have AIDS or the HIV infection, then it's going to be B20. If it says that the patient is HIV positive, then it's going to be Z21. In ICD-10, as well as in ICD-9, there is no code that describes history of. So there is no code at all for a patient that has a history of AIDS. The code and guidelines state to report the code for AIDS, B20. Codes for history of HIV infection does not exist either. You would report Z21. So if the medical record states that the patient has a history of AIDS, then the patient has AIDS. The documentation states that they have that history. It's in the record. You would use the code B20. If the patient's record says that they have a history of, then you will report Z21. But what I usually tell coders that attend any webinars that I host, or if I go in and do a chart audit, I tell them to go back to the physician and get clear documentation. That's really the key, making sure that the documentation very clearly states what the patient's condition is. So let's look at our fourth true-false question. True or false? The code for AIDS, B20, should always be reported as the principal diagnosis code on all patient encounters. Cast your vote. Okay, looks like 73% of our webinar participants say that the answer is false, and we have 26 that's true. So let's recap. The coding guidelines state that you have to code based on what's documented in the medical record. So if the medical record states that the patient has AIDS, and the reason why they're presenting for medical care is directed to the AIDS or the AIDS-related condition, then you will report that as the principal. If the patient's presenting for other medical conditions and they just happen to have AIDS or they are HIV positive, then the AIDS or the HIV infection code would not be sequenced as the principal. So in this case, the answer is false. If you look at the way the question is worded, it says the code for AIDS should always, and if you notice I underlined it, hoping that that would be your hint. In true false, if there are any words, any portion of the statement that is not true, that makes the whole entire statement false. So this is false because you would not report AIDS for every patient. It would be based on what's documented in the patient's medical record. So now let's look at a few coding scenarios. Oh, forgot to take that off. I apologize. A 27-year-old patient presents to her primary care physician's office concerned about recently having unprotected sex and requests a test, an HIV test. I'll skip the blurb about the well visit because we'll look at that in the final webinar series. So in ICD-9, here are all of the codes that you would have reported. B70.0, because the patient comes in for the well visit. The patient comes in for an HIV test, but the doctor also does a well visit. So because the doctor also performs a well visit, the principal diagnosis would be the well visit code in ICD-9, and it would be the same in ICD-10. So Z00.00 is the principal diagnosis. Special screening, Z11.4, HIV counseling, Z71.7, and high-risk sexual behavior, Z72.51. And if you look at the next slide, it gives you the rationale for the selection of the codes that we have. So again, this is a well visit. is the principal diagnosis, Z00.00, the special screening code, the HIV counseling code, and the unprotected sex code, Z72.51. This one is for HIV post-test counseling, and the patient comes back in for their results. The doctor tells the patient that the results are negative, so they don't have the AIDS or they don't have the HIV virus. He does counseling for 30 minutes on the importance of safe sex, talks about contraceptive methods. And so because this particular patient's results were negative and the physician counseled the patient, the principal diagnosis is Z71.7 and the secondary diagnosis is Z72.51 for high-risk sexual behavior. And so if you look at the rationale, principal diagnosis is for counseling and the high-risk sexual behavior code. So this is the same patient. They come in for their results, and the physician tells the patient that they are HIV positive. So because this patient's results are positive, HIV positive, the principal diagnosis is Z21. The secondary diagnosis reflects counseling, Z71.7. And in actuality, you probably could have also reported the Z72.51 in this case also. So the third diagnosis, depending on what is noted in the chart, is Z72.51. So here again is the rationale. The physician counsels the patient on the HIV test results of HIV positive. The discussion about the difference between HIV positive and AIDS, and also the importance of safe sex practices. So Z71.7, and then Z72.51, the third code. Same scenario, but now the patient is diagnosed with AIDS. The principal diagnosis is B20. The secondary diagnosis is for counseling, Z71.7. And the third diagnosis, Z72.51. And then here's your rationale. Physician counsels the patient, explains in detail what HIV infection is. He initiates a treatment plan. They discuss medication and the importance of safe sex. So this diagnosis for AIDS, B20, counseling, Z71, and then Z72.51. So this is a patient, same patient, or rather similar example. This is a patient that has the HIV-2 virus. In terms of reporting, the principal diagnosis is going to be B20. The secondary diagnosis is B97.35. The third diagnosis reflects counseling, Z71.7. And then this one, this particular example doesn't have enough detailed information, and so we're not going to report that high-risk code on this particular scenario. Here's the rationale. The physician counsels the patient, talks about the infection, initiates a treatment plan, discusses the importance of taking meds, and the importance of practicing safe sex. So here are your three codes. This one is counseling without any testing. So the code for counseling is the 71.7, and there are no other codes on this particular encounter. The patient declined HIV testing, so there's no code described that the patient declines because they have the right to decline. So you would just document that in the patient's record. Antiretroviral therapy for a newborn patient. So this is a mom, an HIV positive mom, that brings their baby into the pediatrician's office for a follow-up for a 2-month-old. The physician does history and exam, and they discuss the lab results. The patient's medication, the newborn's meds, were modified, and he also revised the treatment plan. So since this one is an inconclusive, or for this particular baby, the principal diagnosis is R75 and pre-exposure prophylaxis Z20.6. So these are your two codes. There are no other problems here in terms of the baby. The baby's not sick, so these would be your two codes. If the baby, if the mom indicated that the baby was sick, maybe they had an ear ache or an ear infection, the code sequence would still be the same. Well, in this case, actually, because the baby comes in and the mom says, "Oh, my newborn has an earache or an ear infection," and the doctor maybe diagnoses otitis media. The otitis media would be the principal diagnosis, and then you would still have these R75 and Z20.6 codes on that particular encounter. So here's the rationale for just coming in for antiretroviral therapy for the newborn, R75 and Z26. But again, as I stated, if the if the mom indicated that the newborn had a fever and maybe there was something with the ear, and the pediatrician diagnosed otitis media, then you would utilize the otitis media code as your principal, and then this would be your third, and then this would be your fourth. Okay. Office visit AIDS-related. So a patient comes in with a history of AIDS to their primary care physician. They complain or fever and extreme fatigue due to possible pneumonia. The final diagnosis that the physician documents in the record is pneumocystis carinii pneumonia and AIDS. And according to the coding guidelines, because this represents an opportunistic infection or an AIDS-related infection, the principal diagnosis in this case is going to be B20, and the pneumocystis carinii pneumonia is the secondary diagnosis. So that's the coding guidelines. Anything that qualifies as an opportunistic infection will always be sequenced as the secondary code. And so that's basically what this rationale says. Anytime a patient has an opportunistic infection, you will always have a minimum of 2 diagnosis codes. The principal diagnosis code will always reflect the AIDS, and then the AIDS-related condition is always going to be the secondary. Okay, here's another office visit non-AIDS-related scenario. Well, this one's office visit non-AIDS-related. So this is a patient that comes in to your practice with a history of AIDS, and they just recently had a procedure, total abdominal hysterectomy. They come in with complaints of nausea, vomiting, and dehydration due to chemo that they had earlier. The patient also needs refill of their meds. So if you'll notice, because this patient came in due to the nausea and vomiting from the chemo, the nausea and vomiting due to chemo code is the principal diagnosis, R11.2. Dehydration, E86.0. The patient is still actively being treated for the cancer condition, even though they had their cervix removed, C53.0. The coding guidelines state that you have to also report a code that describes adverse effects of the chemo. So that's this T45.1X5A. So if you remember earlier in the presentation, we were talking about the 2 types of 7-character codes. Well, this particular code has not only the dummy placeholder X, but it also has the alpha A for initial encounter. Let's erase that so you can see the code. In the code book, the code book displays a T45.1, and in order for you to have this code, as the correct code for reporting purposes, you would need to place the dummy placeholder X. And because this patient is receiving active treatment for this condition, the A for initial encounter is used for this particular scenario. The patient has AIDS, but that's not the reason why they came in for medical care today. Today they present for complaints of nausea, vomiting, and dehydration. So the final diagnosis is B20. This slide gives you the rationale. Nausea with vomiting due to chemo, dehydration, cervical cancer, because and even though the patient had the procedure, they're still receiving active treatment for this condition. Adverse effect of chemo, and AIDS is the fifth diagnosis. Here's another office visit, non-AIDS related. This is for a pregnant patient. So again, the coding guidelines state that if a patient comes in and they're pregnant, the pregnancy codes take precedence over any other codes in the code book. So your O as in Oscar 20.0 is the principal diagnosis for this patient that came in with complaints of severe cramping and heavy bleeding. The O as in Oscar 98.712 is the secondary diagnosis. And if you notice, this is a six-digit code. This patient has a history of AIDS. So, and even though they are coming in, you'll notice this is the third code and not the first code. So going back to that example, going back to that polling question, here is an example of why the code would not be sequenced as the principal diagnosis, because the patient is not coming in specifically for care related to the AIDS infection. They're coming in for care related to the pregnancy. So this slide just gives you the rationale. And at the bottom of the screen, it says that if the patient was HIV positive versus HIV infection, then you would report Z21. So if the patient was HIV positive and they came in with all of these complaints, then instead of reporting B20, you would report Z21. Office visit for a staff member. So a medical office assistant was drawing bloods for one of your patients, and they accidentally punctured their finger. So the office manager completes the workplace injury forms, and the physician sees the medical office assistant. They provide a supply of 48-hour medication, counsels the patient regarding transmission prevention, and the blood work is sent to the lab. So here are your four codes: special screening, Z11.4, pre-exposure prophylaxis, Z20.6, counseling, Z71.7, and because this medical office assistant punctured themselves with a needle that was used to draw blood for a patient that has AIDS, we're using the W46.1, and if you'll notice, this is a 7-digit code, and because it's a 7-digit code, it has two dummy placeholders instead of one. And because this care, the care that this patient is receiving is initial and it's active, the seventh character is A. So here is the rationale for the codes that we reported. I think I see a question. There is no code for condom distribution, unfortunately. So let's move on. We spoke a lot about codes, so now let's talk about how those codes impact your revenue. Currently, most of the health insurance plans that you participate with reimburse based on a risk-based methodology. Historically, everything was based upon the CPT code that you reported, but now everything has shifted to diagnoses. So it's very important that when a patient presents to your practice, all of the medical problems that you address must be reported, or rather, I should say, they must be documented in the medical record so that when you report those services, you can report those services to the health plans and you can get the appropriate reimbursement. So remember, the reimbursement is now 2 layers. It's the traditional reimbursement that you get from submitting your claims, and now it adds in that layer of quality measure incentives for any of those chronic conditions that the patients may have that your practice may be managing. And HIV and AIDS fall into that chronic condition risk pool category that generates additional reimbursement to your practice. All patients are assigned a severity level based on the number of chronic conditions that are being managed. And so the higher the risk score, the more reimbursement your practice receives per patient that's in those various risk categories. The patient demographics includes any of those services specific to all of those chronic conditions that you're managing, and what happens in terms of how that's calculated. They look at the claims that you're submitting. They also look at any of the pharmacy data specific to those prescriptions that you're giving to your patients. And so all of that needs to be taken into account when you're managing the care of the patients that present to your practice. So just some diagnosis coding tips. Make sure that you assign all of the codes that describe the reason why a patient came into your practice. It doesn't necessarily have to be medical related. Again, we spoke about the well visit codes. Patient is not sick, but they're coming in for medical care nonetheless, specific to a well visit. So you want to make sure you report all those codes. If a patient has significant chronic conditions, the physician should be managing those, and those should be documented as well as translated to a code on your claims when you submit those to the insurance carriers. In terms of AIDS and HIV positive, those diagnoses impact your reimbursement, especially if you rely on quality incentives from the QAR measures, the HEDIS and TQRS. So it's very important that you make sure that you're reporting all the codes that map and tie into all of those conditions that are being treated in your practice. Any medical conditions, or rather I should say any codes that are reported on claims, you have to make sure that those are documented in the record. Because when they come out to do a chart audit, they look at the record to validate the codes that are reported on those claims. Code sequencing is also important. We looked at some codes that are specifically designated as secondary versus primary and vice versa. So in terms of sequencing, remember we said also that if a patient has, if an HIV positive patient has a reason to come in for medical care, but it's not specific to the HIV infection, the reason why they came to your practice would be sequenced as the principal diagnosis, and the AIDS or HIV infection code would be sequenced as the secondary. So you always have to look at your coding guidelines to determine that you're reporting all of the codes and that you're sequencing those properly. So the opportunistic infections. So we spoke a lot about the opportunistic infections. So if a patient has an opportunistic infection or an AIDS-related condition, the ICD-10 code for AIDS is always the principal diagnosis. And if the patient, and the opportunistic infection code or the AIDS-related code is the secondary diagnosis. So in terms of a patient that has any of those AIDS-related conditions, this would be the only time AIDS would be sequenced as the first code. Now, keep in mind, the patient may come in for other problems during that encounter. So let's say, for example, let's say a patient came in complaining of a headache, and they also have AIDS, and they have one of those opportunistic infections. because they present it for the headache. The headache is the first code, B20 is the second code for the AIDS, and the opportunistic infection code would be a third code. So keep in mind, everything ties back to the reason why the patient presented for medical attention. That's how you would think in terms of your code sequencing. In the off chance that you're still using paper charts and you're losing out on all that money that the government is giving out for electronic medical records, please make sure that you're using standard medical abbreviations, acronyms, and symbols. Try to limit the use of the up and down arrows and instead use the terminology hyper or hypo. It's very important that you take a look at your practice if you're still using paper charts, because down the road, the government will start to look at negative incentivizing those practices that are not using electronic records. And at this juncture, you may have actually missed out on that opportunity to get those incentives that CMS and your state local Medicaid agencies were giving for transitioning over to an electronic medical record. They were giving out tons of money these last couple of years. All righty. In terms of some more documentation tips, every visit that a patient comes in for must stand on its own in terms of what you document. So, for example, if a patient presents today, the chief complaint should not read "see previous note," because when an auditor comes in, they're not going to look at the previous note for the details of the reason why the patient presents today. Those details should be in that note, and that visit must be able to stand on its own to establish why that patient came in for medical care. You should also make sure that you document chronic conditions for those patients that are coming in on a routine basis where you're treating those chronic conditions. Also important, if you have patients across the board, not just payer specific, whenever the patients come in for the first time of the following year, you should always go through that process of redocumenting all of the medical conditions that you're treating. Because specifically, if you have patients that are dual eligible and they have Medicare as the principal insurance, as their primary insurance, and you rely on quality incentives for PQRS and any of the measures that CMS Medicare affords, if your patient has chronic conditions, even though the patient may be managed in your practice for a long period of time, if you don't report the diagnoses that reflect those chronic conditions, your risk scores are going to go down and your reimbursement is going to decrease. So you want to make sure every year when patients come in for the first time that following year, you can start to chart by saying patient is an established patient here for diabetes, hypertension, and AIDS. They need a prescription refill. So you want to do that routinely every year when the patient comes in for the first time. Problem list. It's important to note that coding from the problem list is unacceptable. Anytime a patient has medical conditions that are noted on the problem list, the physician must elaborate a statement that details the status of those problems if that's what you're treating that encounter. So if the patient is HIV positive, you could say something like stable on meds or non-compliant. Any other medical conditions that you may be treating, diabetes, congestive heart failure, COPD, you would just mention the status of that condition. So again, to reiterate, coding from the problem list is non-compliant. When you have medical conditions that are on the problem list that are being managed, you should bring that down to your assessment and plan section in the record and just summarize what you've done for those medical conditions for that day. Medical record documentation is important not only for insurance purposes, but it's important because it tells the story of what you've done for that patient in terms of how you're managing their care. It also helps for continuity of care in case you need to send the patient to a specialist or if the patient is being followed after hospital care. So it's very important that every record has a chief complaint. It establishes medical necessity. You list all the diagnoses that you treated, and if you sent the patient for any special diagnostic tests or any referrals to specialists, all of that needs to be stated in the record. So this should be our final case study. I'm going to give you some time to look at this. The patient returns for a test result, but they also need prescription refills for hypertension. The physician spends some time counseling the patient, discussing their results. The patient has a confirmed test result, so the patient now has AIDS. He counsels the patient. He discusses the importance of safe sex, distributes some education literature, documents a treatment plan, and he also checks the patient's blood pressure and determines that it's unusually high. So he gave the patient some medication or increased the dosage of the hypertension meds and referred the patient to see a nutritionist. This is a true or false question. The principal diagnosis is hypertension. So let's recap. The patient came in. They were specifically coming in for their test results, but they also needed a prescription refill. The physician informs the patient that they have AIDS. He counsels them. He discusses the importance of safe sex, provides them with some education literature, implements a treatment plan. He rechecks the blood pressure, changes the medication dosage of the hypertension meds, and I want to know if the diagnosis for this encounter, specifically the principal diagnosis, is true or false. And we have 59 folks on the call, but it looks like only 24 have weighed in. Come on, everybody, let's give it a try. This is our last one for the day. Come on, everybody, let's give it a try. This is our last one for the day. Going once? Going twice? Okay, well, it looks like 83% of the webinar participants state that this is false, and we have 16% that say it's true. So let's recap. This patient specifically came in for their test results. And because they came in for their HIV test results, the principal diagnosis of hypertension is false. You will report the diagnosis of hypertension, but because the patient came in specifically for their test results and the doctor informed the patient that they have AIDS, the principal diagnosis is AIDS, B20. And the secondary diagnosis for this encounter is I-10. Oops, I'm sorry. Ooh, this pen is. Ooh. Okay, I think my mouse is acting up. So the principal diagnosis is B20 for AIDS, and the diagnosis incidentally for hypertension is I-10. So the secondary diagnosis is hypertension, I-10, and the principal diagnosis is AIDS. So my closing comments. Documentation is very important. Coding is important also, but documentation drives your reimbursement because it determines the codes that you're going to report. You should make sure to report all chronic conditions as applicable to those encounters. So if a patient comes in with chronic conditions, if you're managing those chronic conditions, that encounter, then you should report those because they tie in and significantly impact your QAR, your HEDIS, and your HCC risk adjustment. HCC risk adjustment speaks specifically to the Medicare population. It's very important that you report all the diagnoses that tie in to the care that's documented in the medical record, because the diagnoses is now the key determinant in reimbursement. in terms of the additional reimbursement. The principal diagnosis should always reflect the reason why the patient came to your practice for medical attention. So if the patient's not sick and they came for a well visit, then the visit code is the principal diagnosis. Patient for the test results, and the code for the test results is the principal diagnosis. Whatever the reason why the patient presented for medical care should be documented in the record, and all of those diagnoses should be sequenced accordingly. But the principal diagnosis should reflect the reason why the patient came in, or if the patient comes in for a medical condition that is exacerbated, the exacerbated diagnosis would be sequenced as the principal diagnosis, because that's going to be the diagnosis that you spent the amount of time trying to bring under control. So it all depends on how the encounter, what happens during that encounter. What happens during that encounter. Any claims that you submit, not just to your local Medicaid state agencies, but to your health insurance plans that you participate in, the claims that you submit in terms of the codes should match the diagnoses or the medical conditions that's documented in the medical record. Medical necessity is the key criteria in determining how the claims are going to be paid. So if a diagnosis does not support the procedure or service that you reported on that claim, it could possibly be denied. But more importantly, if the insurance carrier or the state come out and they do a chart audit and the documentation doesn't support the claims, they can retroactively take money back. So closing comments. Documentation inaccuracies result in payment recovery and heavy sanctions from not only the Medicaid Office of Inspector General, but also CMS. Each insurance company has a recovery entity that recoups money whenever information that's documented in the record does not support what's submitted on the claims. So in terms of sanctions, penalties, you could be restricted or excluded from participation from the Medicaid program or from the insurance plans that you participate in. If you currently participate, they could terminate your status. There's fines that could be involved. And do not pass go and end up in jail. That would be the most egregious sanction or penalty that would be in terms of your documentation and coding inaccuracies. So it's very important to make sure the point that we want to take away is that whatever you document and whatever you submit on your claims, they should match. There should be a one-to-one match. So here is just a summary of the web resources that were used for the presentation. Some additional web resources that are specific to coding. Some coding resources, ICD-9, ICD-10, the Faye Brown ICD-10 Coding Handbook, ICD-10 Fast Finder. And that concludes my portion of the presentation. I'm going to turn it back over to Samantha.
Great. Thank you so much, Stacey. As we've run out of time for today, we're going to ask all participants who have direct questions for Stacey on anything they heard today to please email Samantha Ritter at samantha@healthhiv.org. We have also sent out the resources and guides for this presentation via email. If you have any questions concerning those, please also email Samantha. And finally, we'd like to thank you for joining us in today's webinar. And if you have any further questions on anything else, please email Samantha@healthhiv.org. Thank you.